Thank you very much. So we're going to talk to you about a review we did of the North West urgent care pathways and acute hospitals and how that was impacted over the pandemic. Just to introduce first, my name is Kelly Bishop. I'm an Assistant Director of Nursing and Urgent Care. I wanted to introduce that first because actually our work's about collaboration of data scientists and clinicians. So I work with a team of clinical leads that we've all worked in the urgent care pathway, and we work closely on one team of data scientists clinicians. So that's a really important aspect of our talk. So what did we do? Very briefly, there's 25 sites in the northwest of England that were in our core of the northwest type 1 sites. And what we did for each site is we looked at 218 measures for each site, and we looked at those as a team of clinicians and data scientists together. And from that, we developed key lines of inquiry. And these key lines of inquiry we then took outside and worked and walked in the pathways with the clinicians on the sites to triangulate them with that clinical and operational reality. So what we saw, what is, and what the recommendations were. We did multiple reports by each of these trusts that we visited. We then aggregated the reports up to ICS level, and then we did a final aggregation up to regional level, just to give that real recommendation at different layers. Good to hand over now to Andy McCann, who is the lead data scientist for this programme. Thanks, Andy.
Thank you, Kelly. And yeah, I'd just like to echo as well. It's a privilege to be able to work closely with clinicians like Kelly, who can bring their wealth of experience and system understanding. And we tie that in with the data work that we do, supported by the wider CSU, BI, and data warehousing teams. So, as Kelly said, we did very detailed packs for each site visit. I don't think we've got time to go into those here. So we'll look instead at some of just the very high-level findings from some of the system-level outputs. And to put a bit of context on that, when we started this project, which was just the very beginning of 2022, there were other reports coming out talking about the impact of COVID on urgent care, and talking about it in a similar way to the effects it had on the elective system and wider health system, of being exclusively negative and a very sudden shock. Yet, in fact, that's not actually what happened in urgent care. So measures of performance, 4-hour performance, is obviously not a perfect measure, but it's one of the best we've got, and certainly one of the longest running. So here's a full decade before COVID, 4-hour performance across England as a whole. And as you can see, it was on a very clear downward trajectory. Seasonality on top of that, we generally performance worse in the winter, a partial improvement in summer, but on that very clear downward trajectory. And counterintuitively, certainly the first year of COVID actually saw much improved AE performance. It was the best it had been in 5 years. And it was only really, there's a bit of a deterioration there in winter 2021, but for different reasons, not the usual seasonal respiratory issues, but other issues that were going on at the time. But then a recovery again in the spring. And it wasn't until summer 2021 that performance fell below that long-term trajectory. So why was this? Some pretty obvious reasons. So this is now showing for the Northwest. Attendances, pre-COVID there, we can see, dropped to less than half immediately in the onset of the pandemic. And probably more importantly, bed occupancy, which had been well above 90%, dropped to closer to 50%. So the immediate effects on flow, despite infection prevention control, red and green pathways and so on, were in fact that beds were far more available, and so flow through ED of those people who did intend was actually greatly eased for a long time. What we think happened, though, and Kelly will talk about this at the end of the talk, is that other factors were emerging at this time which would negatively impact on performance, but they were masked by this initial improvement, so they weren't obvious until a considerable amount of time later. It was only sort of, as I say, well after April 21, sort of into the summer of 21, when attendances and occupancy were returning closer to normal, that these factors had an impact, and they certainly did have an impact. And by kind of late 2021, I think everyone acknowledges that EDs were in an unprecedented situation, facing unprecedented pressure. We want to unpick a little bit more what that pressure was all about. So this is a way we chose to look at it. People were talking at the time of departments being busier, which they certainly were. Certainly in terms of how many people are in the department in a point in time. So that's what this chart's trying to show here. We've picked a period in late 2021, September to December, and compared it with 2019. So you kind of bluey green thin lines there. Each week of late 2019, how many patients in the department at a point in time, at an hour during the week, and then the thicker bluey-green line, that's the average. And the red is for the same period, September to December, for 2021. And you can see that even the quietest weeks in 2021 were actually busier than your busiest weeks in 2019. These departments were a lot busier. This example department was, on average, 61% more congested than it was in late 2019. So why? Hearing reports there, we're involved in like the Lancashire and South Cumbria System Control Centre and so on. People talk about it's just the demand. We can't cope with it. And a lot of people talk about it imagining that it is just footfall. But if you do the same chart of how many attendances there were across the weeks, far less difference. And in fact, here we've picked one which did show one of the bigger increases, 10%. But even here, you've got a 10% increase in attendances, and yet there's 60% increase in patients in the department in a point in time. So yes, people feel busier, but it wasn't fundamentally due to footfall. And the obvious implication of that, I mean, it's a mathematical certainty that means that the average time that people are waiting in department was far longer in late 2021 than 2019. And it's that had the bigger effect on this congestion, this busyness, than the actual attendances. And we can look at that across all the sites that we looked at. And you can see the effect of this longer wait times, backlog building up, that almost everywhere the increase in congestion is far higher than the increase in attendances. Notice the different scales here. This dotted line will be if they increased in proportion. So all these sites up towards the top of the chart show far more increase in congestion than they did in attendances. Indeed, some saw fewer attendances, and yet they were still busier because they had more people in the department at a point in time. There are a few exceptions down there at the bottom, but I point out they're generally smaller departments. In fact, some of them even closed overnight, so they didn't have that opportunity for the backlog to build up. I think another important point is how this happened gradually, this sort of creeping normalisation. So if we go from when this particular department was at its quietest at the onset of pandemic, the increase in the average number of patients in the department per week is less than one extra patient per week. You hardly notice it happening. But over 18 months, the cumulative effect of that is a department that's 4 times busier than it was at that quiet period. And perhaps, I'm not sure, but perhaps this is part of the reason that if we had a very sudden shock, maybe the big increase we've seen in waits of over 12 hours, corridor care, it happened, but they were quite unusual pre-pandemic, have now become normalised to the point that we have to mark spaces of corridors because that's where the trolleys are going to be. We know we're going to have trolleys there all the time. And so why was this? Kelly will talk in more detail, but one obvious thing is waits for beds. So the chart at the top there, mean time in department for admitted patients, you can see how much it's increased post-COVID compared with even the worst period in winter pre-COVID. And most of the increase is for admitted patients. The increase for non-admitted patients is less. There's clearly an impact. If your cubicles are being used for admitted patients waiting for a bed and so on, there's going to be an impact. But it's clearly largely to do with admitted patients. And so the obvious implication of that is it's largely to do with bed availability. And that in itself, affected by the very large increase in length of stay we saw from kind of late 2021. Obviously, if you've got a longer length of stay, you can admit fewer people to the same number of beds. And that in itself, we think largely, not exclusively, but is going to be related to discharge issues. And Kelly will talk through that and a few of the other reasons that we think impacted the system.
Okay, so what happens when we took this data knowledge onto the clinical sites and worked with the clinical teams to discuss it? So what Andy's articulated really well there with the data about the congestion. So A&E is busier, but there's not necessarily more demand for A&E to reflect it. And actually what we found was during the COVID period, when the pressure was off A&E, and actually it was a really good time. A&E staff say this is the best time we've ever worked in A&E is COVID. You know, the hospital floor, it was a brilliant time for them. But performance was so good in A&E, and it was so different for them then. There was a wheel, we called it the silent circumstances. It evolved. I'm shouting now. Sorry. I've blown the mic. Nope, completely
That's
broken.
it.
Back on. Okay, I'll do it this way. Yeah, silent wheel of circumstances. So what happened basically is clinical models changed, operational models changed, and it wasn't particularly spotted because it was actually quite a good time in terms of A&E for COVID. So just to go through those very briefly, admitted waves. Okay, so what happened actually during COVID that impacted when the tap was turned back on, that we really felt it. So what happened is actually the operating model for MAU, Medical Assessment Unit, changed. The A&Es became a de facto medical assessment unit. Okay, so that whole clinical and operational model needs now to be reset. It hasn't been reset, and EDs are operating with acute physicians, and that is not the way they were built to be. The environment's changed. So as red and green pathways had to be implemented in ED, they actually bolted on bits of ED estate everywhere. So if you think about numbers in ED now, the ED estates aren't what they were pre-pandemic. They look different, they feel different, their pathways are different in a physical environment. Direct admission pathways, this is absolutely, you know, a graph to tell a story for me. So pre-COVID, these new direct admission pathways, this is COVID, it was turned off. This is because everybody then went through the front door of A&E so that it could be tested IPC for COVID. And you can see, when we go back to normal, those direct admission pathways have not gone to pre-COVID standards. So that tap's been turned back on, but nowhere like it was pre-COVID. So it's still the front door of the hospital, and it's gone backwards since since before COVID. Demand, you know, we've talked about this, and I've been listening on previous about demand, and it's hard, and we've had discussions in data to actually demonstrate through data how frail a patient is, comorbidity is poorly. But you can walk through any A&E, and you don't have to be clinical and look at the patients on the trolleys to actually be able to see that those are really poor patients that are really complex. You know, anybody can do that. So, you know, you can see that the clinical staff are reporting these are complex patients with multiple comorbidities. Infection prevention control, what we did see and what we saw talking to the staff and looking at the data was during the pandemic, there was a rise in ward moves. There was multiple ward moves. That will probably happen through every winter as we think about our infection control processes in the hospital, trying to get the patient to the right place. And the more ward moves we have, the longer the length of stay, and we know that through data. Length of stay, you know, this is well known, length of stay has gone up greatly in all hospitals. NMC to our data is much higher, and also patients more complex, so they need to be in hospital for longer for genuine needs as well. And last couple really is bed occupancy. So we talked about bed occupancy, how that's now is not particularly any higher. We can actually see that it was lower for a period, but because patients are more complex, because IPC, you have to clean the rooms, you have to turn them around, because the workforce is more strained, and actually they haven't got the resources to turn the rooms around quick enough and get the patient flow. So it's a lot more complex than just bed occupancy. And very finally, last minute, we did recommendations through all these triangulation. So I just want to point out the key ones for you. Admitted waves, you know, mentioned this, reset MAUs, absolutely need to focus on that. Direct admission pathways, we need to go back to the pre-COVID focus on direct admission these patients and not going through ED. Demand, I want to just focus on some longer-term planning, considering more complex deep conditions and older patients. Please, the data scientists, analysts in this room, can we look at this? I'm a nurse. I haven't got the ability to look at this. I can look at that clinically, but if we can demonstrate this in data, that's really useful. Data here, deeper analysis into the impact of the pandemic or any IPC outbreaks into the number of ward moves, patient experience, and then that subsequent increase in nosocomial rates. Again, that's an ask from me as a clinician. That would be really good if that could be cracked. And a couple more just to highlight, because time's nearly up. Length of stay, whole system visibility, NMC2R, and community flow. That back end of the pathway, so it's visible. And I think the final one is reviewing ED pathway footprints. You know, what do EDs actually take now from an estate point of view? What is their, you know, their new numbers when we talk about congestion? Not what were the numbers pre-pandemic, what are they now? That needs reviewing. So just to finish that, us really, I suppose just to, you know, reiterate it, is that absolute, Andy and I are like Team McCann Bishop in terms of clinical and data, and it's a really, really interesting and debate, and we have some, you know, fantastic conversations. So we've got our details there. We're a nursing and urgent care team for the CSU. Thank you very much.